joining this for this session. Like it says on the Happy New Year to you. Am I too late for Happy New Year? 10th, I don't know. An introduction to funding in general practice. So my name's Jason Carrigan. I work for Midlands and Lancashire Commissioning Support Unit. As an organisation, we mainly work with ICBs, the old CCGs, but we do work with providers, and we do some primary care work as well. And we do primary care finance, especially around PCN, primary care networks accounts. So we do, we're quite experienced in this element. Now, when I'm talking, I don't think I'm going to be able to see if you put your hand up. So if you've got any questions as we go along, please just shout up. Come off mute and say, "Excuse me, I've got a question," and that's absolutely fine. Because, like I say, I don't think I can see hands up because I'm presenting. Okay, so just a quick overview of what we're going to go through. We're going to go through the sort of core contract of general practice. We're going to go through the quality and outworks framework, which is the QOF framework, enhanced services, premises funding, community-based services, primary care networks, which I just mentioned, and then really from there it's other forms of income as well, which is general practice IT, prescribing, NHS England payments, and local authority payment. So the first one really is GP core contract, of which is roughly around 40% of the overall income a GP practice will get. Now there's really three types of contract. There's general GMS, general medical services. There's PMS, which is your personal medical service, and there's APMS, which is your alternative provider of medical services. Now, your general medical services are your traditional sort of general practice model, where you have a number of GPs. It doesn't have to be GPs, it can be nurses, it can be business managers, etc., are partners in the practice, and they take home what's left of the profits, maybe potentially, or surplus in a year, and that's how they sort of get paid. There's PMS services, which is a bit like general medical services, but it's a bit different in terms of it has extra sort of responsibilities. It has has extra contracts and maybe additional sort of payments to nurses or different elements to it that has been agreed with the commissioner over the years. And then there's the alternative provider of medical services, the APMS, which can be a different sort of model altogether. So that's something like maybe your Virgin Care or a different type of model, a different type of provider rather than your traditional, GP partner sort of model. So if we just go through sort of the basic funding of the GP core contract, it's list-based, and it's based on the Carhill weighted capitation, and that's based on a number of different the different areas, the Carhill weighted capitation. It can be age, it can be the market you're in terms of staffing, so things like London might be a bit more, etc. The morbidity and what your mortality is in your area, and it can be how many residential patients you might have in there as well. So there's different things that go into the Carhill formula to sort of say, so if you've got a list size of 10,000 and your age and your morbidity, and if you're in a poor area, then that Carhill weighted capitation might push you up to say 10,500 or maybe even 11,000 patients, and that will obviously give you more funding over some of the other practices that maybe have a different age range or in a different area. So just to give you an example, sort of value per patient of each patient now is 99.7 £99.70 this year, and that's paid monthly, but that's the annual figure, that £99.70. So it's that multiplied by the number of patients you have in that Carhill weighted capitation. The list size is adjusted quarterly, and that's for many. It doesn't change much, but it might change a few. And you know, if you have new estates or if you have a new practice that maybe starts or whatever, then there are changes that sort of happen on a quarterly basis. And you can opt out of core services as well in terms of some of the things like out of hours childhood vaccinations and immunizations, etc. So that's your sort of main sort of GP core contract, really. Going on to quality and outcomes framework with your QOF. This is based on a points-based system. It's sort of an incentive scheme for GP practices to do over and above the sort of regular normal, your normal sort of GP services that you would expect. So, the QOF basically pays to do flu vaccination and cervical screening, maintenance, prescribing indicators, early diagnosis, early cancer diagnosis, things like COPD, long-term condition registers, and additional sort of work with some of these patients that have got long-term conditions. So the idea of QOF is to do this over and above the normal sort of GP core services as such. Like it says here, there's 635 points available in 22-23, and each QOF point is valued at £207.56. So the way it's sort of billed is through the average practice list size is 9,374. So if you have a practice list size of 9,374, you will get 635 points if you hit all the key performance indicators that the QOF scheme has. So if you have a list size that is, say, half of that, say 4,000 list size, then that QOF points available goes down in a pro rata way. Likewise, if the average practice list size is, say, 12,000, then the points available go up again. So again, it's sort of weighted in terms of the size of the practice. But again, like you say, it's something that the practice has to work on and has to deliver to get its 635 points. Most don't get full points. If you can get something like 550, something like that, you've done pretty well in a year. So, that's the sort of money that is potentially available for sort of QOF and what they're looking to do. Okay, so going on to the next one. So enhanced services tend to be direct services that have you've sort of negotiated or with your local commissioner. Now, obviously, it used to be a CCG, and now the sort of ICBs. So this can cover. It mainly is things like minor surgery. So it can be lumps and bumps that are taken off and other things. So some practices do vasectomies and things like that. They do learning disability health checks, deregister patients, but these things that tend to be a direct sort of directly commissioned by the commissioner to certain practices within a locality, and like you say, who do over and above the normal core services of a GP practice. Another thing that gets funded is the premises. So practices are reimbursed again by the commissioner for their rates, non-domestic rates from the local authority, water rates, clinical waste, and their rent. So whether that's their notional rent for properties owned by the partners, i.e., in a way, potentially the mortgage as such, the actual rent for properties that are leased, and health centre rates for properties owned by NHS Property Services. What they don't pay for is the energy, but I know that's been heavily price capped by the government after all the rises that have happened in the last sort of 6 to 7 months. They've agreed a price capping for GP practices because there was quite a lot of consternation that that the prices have gone up too much. Okay, so that's premises. You also have community-based services, and again, these can be locally commissioned services, and again, these are things just separate agreements, usually done on a price per activity or a block arrangement, but a lot of these type things are sort of price per activity, and these can be things like running like minor injuries clinics, near patient testing, phlebotomy. Not sure how much, I mean, certainly in our local area, I think phlebotomy services have been centralised quite a lot, and there's not much, I think, that's done much on phlebotomy, but I don't know how that works elsewhere in the country. Things like travelling families, catering for them, INR monitoring, and H. pylori breath testing. So again, just certain activities that, again, the practice can earn additional money by doing additional services over and on top, again, of core services in these areas. Right, and now back into primary care networks. Now, these were introduced in July of 2019. And what it is trying to group locally, within a local geographic area, a group of GP practices, and it typically serves a population of between 30 and 50,000. Now, there are outliers in this, and there's some very big primary care networks that are over 100,000, but it tends to be around that sort of 30 to 50,000 pound, patient sort of block, and it tends to be anything between sort of 4 and 8 practices tend to be in that sort of arrangement. So member practices receive a participation of £1.76 per weighted patient just to be part of the primary care network. Now, this is where the majority of the money that is now going into general practice is going into primary care, and it's through the primary care networks. And I'll come on to think which will be additional roles reimbursement scheme in a bit, which is huge money for PCNs. But let me just go through the other sort of areas where the money comes through as well, as things like support payments for a clinical director. So, like you say, there's funding for a quarter of the time of a clinical director of the PCN, just to cover the meetings and any admin and stuff like that that needs to happen. There's a core primary care network payment of £1.50 per patient, and that's to cover things like general expenses, but also things like a PCN manager who will do the day-to-day sort of work through the PCN. You get extended hours access now that's changed to enhanced access. So like you say, any out of hours services now tend to go through the primary care networks. And again, they're done as a locality. So it might be that one practice opens one night and another practice opens the next night, or it might be, a couple over a geographical area, open on a Saturday morning or something like that to give extended hours. You've got impact and investment fund, which again is an indicator-led thing, and there's a number of indicators in that sort of IIF funding, which the PCN can get paid for again if they hit the key performance indicators for that. There's leadership and management funding, 70p per patient again. And then, like you say, the biggest element really is the workforce reimbursement, which is the additional roles reimbursement scheme. And the national funding is increasing from 634 million in 22-23 to 891 million in 2023-24. Just to give you just a real average of what that means in terms of each PCN will basically have a budget in 22-23 of around 650,000 pounds to get in these additional roles, and I'll show you what them additional roles are in a second. And that is increasing in next year to something like 750 to 800,000 pounds per PCN. So it's, that's big money per PCN, per sort of 4 to 6 practices. That's major sort of funding that's gone in to help GPs and help with the workload, etc. And I'll talk you through them in a second. Also, there was things like COVID vaccinations patient payments. That's still going, £12.58 per vaccination. And there's other payments such as winter capacity funding. That's another £250 million nationally that went in, which on average is about 24k per PCN. So just to let you know what these additional roles reimbursements are, these are the main additional roles that can be employed by the PCN. So you can have clinical pharmacists, pharmacy technicians, social prescribing link workers, health and wellbeing coaches, care coordinators, physician associates, first contact physiotherapists, dietitians, podiatrists, OTs, etc., etc., etc. Yeah, we've got paramedics in there. That came in this year. Advanced practitioners come in as well, and sort of adult mental health practitioners again are a relatively new one, and that's, you get 50% funding for that. So 50% remains with the mental health trust, and 50% is paid for through the additional role reimbursement scheme. So again, if you're looking at next year's funding per PCN, on average, you're looking at something like 750 to 800,000 pounds worth of funding. It can be made up of whatever staffing sort of matrix you want to have of these staffing. So just to give you an idea, usually there are quite a few clinical pharmacists and pharmacy technicians that go in. They're very popular roles for PCNs. Social prescribing is again something that tends to either they buy through organisations like Brighter Futures or other organisations such as that, or they employ directly. Health and well-being coaches and care coordinators are again a typical PCN can have anything up to 3 or 4 care coordinators. Physician associates, again, quite new, but can have 1 or 2. First contact physiotherapists. I've been banging the drum for physios to be in general practice for years. Again, that is something that can now happen within primary care. Don't tend to use dietitians and podiatrists as much. I haven't seen them as much in plans, or OTs. But again, things like advanced practitioners and nursing training associates, etc., and paramedics as well are very much in demand. Although trying to get paramedics is not the easiest thing to do. So that, you say, it's a huge sort of budget per PCN. 800,000, and it can be made up of whatever the mix you want of that sort of staffing mix. Okay. Really, this is the last slide, and it's just talking through sort of other payments and support that are made to general practice. So locum costs, so things like maternity, paternity, sickness and suspension. So usually the practice has to pay for the first 2 weeks of any long-term things like sickness or that sort of stuff. So, and then the commissioner or in the NHSE who pays for the locum costs after them first 2 weeks. Things like syringes and needles are there. GP information technology. So nearly, well, all of IT is paid for through like a GPIT scheme through local ICB. So general practice doesn't have to pay for any of that. Prescribing fees and drug costs, and there are some practices that are dispensing practices as well, especially in more rural areas. There's additional sort of money comes along with that as well. Then, like I say, we go into the sort of NHS England sort of commission schemes, things like immunisation and vaccination programmes, support for trainee GPs. So training practices, obviously, you know, there are a number of training practices in the country, so they get additional money similar to sort of training trusts. And then finally, you've got your sort of public health services, things like contraception services, IUCDs, etc., smoking cessation and drug misuse services. So again, there are additional payments made if the practice wants to put on extra work in terms of these sort of areas. So that's the sort of presentation. Anyone got any questions?
Thank you, Jason. As someone who works within a pathology network, I see there's been nothing mentioned about direct access pathology and radiology services that the GPs may request. Does that mean that they've effectively got carte blanche to spend as much of the ICB's money as they want?
Now, that's a really good question, and it's something that someone who worked on the other side for a long time in terms of pathology and radiology was always really keen to sort of kind of limit that, if you know what I mean. At the moment, I think they have got carte blanche, but it's a really good question, and I think some areas tackle that better than others. I know that in my local area there were forms that were made, and you know, and there were things that were for certain things that were grayed out, maybe, you know, in terms of online forms and stuff like that. So you just couldn't tick everything that, you know, was on a particular form at times. But I think that's a really good question. To my knowledge, I don't think there's any limit on that at the moment. And again, I think that needs to be worked through, because, you know, I'm working on both sides. I can understand from the GP side that they just want a good picture, but at the same time, I can understand from the pathology and sort of radiology view that it's you know, that unlimited testing just isn't the answer as well.
The moment, as they're all of block contracts, and they've started ordering all sorts of certainly in my area, all sorts of very expensive virology PCR tests.
And again, I think that, you know, I mean, realistically now with ICBs and, you know, they should be, you should be, you know, the plan is that organisations should be working together for the best use of resources across the piece, isn't it? Really, we're not in that sort of three. You know, when you have providers, commissioners, and you know, and primary care, there's not that sort of. It should now be. I know in theory that's the way it should be, and it probably in reality that's not the way it probably works. But you know, my view is that it's just a constant sort of. You just need a constant communication with all sort, you know, all with your local GPs to try and use the best use, you know, the best use of resources.
Yeah, thanks for that. I would just say we have started engaging with our ICB on this and potentially banning some very, very expensive specialist tests, which really only belong in an acute care setting. But I was just curious to know your view on it.
No,
see if anyone else has got any other view.
Because, like I say, I've worked from both sides and I've seen it from both sides. So, but I think, you know, there are some things that, you know, GPs shouldn't be requesting, should they really? So, you know, and it was all, you know, there was always the argument back in the day as well around, you know, GPs wanting MRIs and CTs, and you know, should they have direct access to that? Well, you know, there's always that conversation. Is it just put an extra layer in, but at the same time, there's only limited resources, so it's a difficult conversation.
It is. Thank you.
Anybody got any other kind of questions? So that was a bit of a whistle-stop tour, really, of primary care and the money that kind of goes through. You're looking at something like £140 per patient. That's kind of a rough sort of element of what each practice gets income for. So if you've got 10,000 patients, then you're looking, you know, at something like £1.4 million worth of income, and that's before you've got things like primary care networks and things like that, which, you know, are putting income in other ways, maybe in terms of additional staff or other things that might be done in terms of vaccinations and all that sort of stuff. So, you know, it's your small general practice isn't that small in terms of money. You know, there's quite a lot there, but obviously there's a lot of costs that go into there as well. Any other questions? No. Nikki, you still there?
Yep, I'm here. Looks like that's it for questions. So thank you very much.
You're welcome. Quite good, because I don't know how many people there. They might have all dropped off by now. I don't know, but
You've still got quite a few. They're saying thank you.
Thank you for that.
You're welcome. Like you say, if you've got any other questions, anything like that you don't want to obviously share here, but maybe you want to share through Nikki or something like that, then please let me know, and then I can come back to you with that. That's absolutely fine.
Amazing.
Thank
you very
you.
much.
Thank you.
Thank you.
Bye.
Enjoy the rest